second time around, you have essentially all of the data, everything is done. It's a completely accurate retrospective snapshot. In the first initial estimate, it's got an element of projection. But this slide, as I say, shows the recent history of the numbers. Looking at it on a service category basis, this breaks out the different components, the different service types that go into the total healthcare expenditures and how they grew during the course of the year. You'll see that hospital inpatient grew at a restrained 2.2%, hospital outpatient at a greater 5.5%, physicians services 1.7%, other professional services, which is a smaller category, 5.4%. Pharmacy spending is at 6.4%. We'll look at that in more detail coming up. That's down significantly from the rates of last year. And then, as you can see, others and non-claims related expenses were relatively restrained. Make a point from those sides. But if you look at the cost drivers, so if you add up the total amount that spending changed from 2015 to 2016, and then attribute that to the components and how much they increase, what you see are the two largest drivers of spending increase are pharmacy spending and hospital outpatient.
Ray, could I go back just
Sure.
for 1 moment? And I think you go into this a little later on. For this slide, the non-claims expenditures, do those translate into administrative costs? Or are these other non-claims clinical costs?
So the non-claims are generally more sort of for care management, those sort of more clinical pieces. It's not for administration.
Thank you.
All right.
Post-acute care would probably be in other professional or physician, depending on the professional component.
So anyway, as I said, these are the cost drivers. This shows the contribution in dollar amounts of the increase from 2015 to 2016. And as I said, pharmacy and hospital outpatient are the two largest contributors.
Is pharmacy a gross number or post rebates?
The pharmacy number is a gross number, so we'll be getting into rebates in, I think, maybe the next slide. Sorry.
Just on the hospital outpatient growth, what is that attributed to? Is there a sense of what caused that increase? Is it services that were given in inpatient setting and now an outpatient affiliation? What is is there any theory to why that number is so large?
Theories?
So our data doesn't really speak to that. We haven't really identified the drivers, but we have seen certainly a slowdown in inpatient growth and an acceleration in hospital outpatient. I think a reasonable mind could see sort of shifting of care there, but our data can't really answer that question. Or this data can't answer that question.
So traditionally, I would just add, hospital outpatient is going to be a focus area for our cost trend reports to dive a little bit deeper. Are these utilization trends? Are they price trends? Are they physician practices that are being converted into hospital outpatient? So that will be something we'll be able to answer a little bit more after.
Great. So one of the, just let me follow up on Bill's question and David's comments. One of the, the handoffs, if you will, is very, what CHIA has done is really critical. But there's a lot more to understand on every one of these numbers. And we're going to be looking, that's what our staff is going to be doing, trying to understand what is underneath the hood, as you pointed out, Ray. In a number of these cases, pharmacies, is it prices, is it utilization, is it changes in the composition of who's insured in a particular group. And so working with this data, we will be digging in over the, and we will be using the cost trends meetings to talk about some of them, plus we will be issuing, where appropriate, special reports. We'll see how that works out. So I think these questions are right on, you should ask them. But, they're going to be, and I appreciate your answer, which are, this is what we had. And we look forward to your analysis. You can put that on us and find out a little more. So thank you.
And it's iterative. We learn our data, I think, reveals things that the Health Policy Commission likes to look into, and then as we understand things that you're looking at more closely, that informs our data collection and data analysis objectives, and we're always trying to stay kind of in sync with one another. The working relationship between the two agencies is very strong, and it's really the communication that comes to that. So.
Well, on Medicare, you have a 3.3% increase. I find that interesting in terms of what that consists of, especially when you look at Part B that went up about over 16% for this year, and but supplemental was pretty stable at under 4%. Like, how do you get to 3.3? Like, how is that weighted? Is that a lot of out of pocket that's been reasonable? Because even prescription drugs in Medicare is very high.
So
I think it's a great number. I'm glad to see that. I just wondering how we got there.
sure. So the Medicare number includes both Parts A and B, as well as Medicare Advantage and Part D spending for Part D beneficiaries. So what we've seen is as pharmacies slowed down in some other categories, it's continued to sort of grow at a higher rate in Medicare and in the mass health sector. So I think that's a big piece of it. I think we saw that Medicare enrollment was slower than in previous years this year, but the spending continued to grow. But sort of at our aggregate data level, I think, based on the per member or per beneficiary data we saw in a previous slide, we can see that it's relatively low or stable, probably due to sort of slower enrollment.
Gave a quick sentence or so about mass health, and I was wondering if we could give a couple more sentences. It is a big share of total spending, so I'm wondering if the 2.8 would in fact be lower, but took out certain extenuating features in mass health, and I'm not sure what those are.
In general, I think this year was more stable than, we're seeing the effects of HCII implementation working its way through the system, and last year there were more significant, I think, disruptions in this year, but you still are seeing, and for this slide in particular, we went back to Mass Health when we saw these numbers, and they sort of showed us some of the underlying program activities that were behind this, but I don't know if there are more detail we can.
I think the only piece that I would add to what Ray said is that we saw sort of stabilizing enrollment this year in the mass health sector. So as we saw kind of spending and enrollment sort of be a little bit more where we would expect, that's why we're seeing sort of PM numbers that are in this 5.9, 5.1 range, where in the past the PM numbers were low, but that's because of such a kind of rapid acceleration of enrollment. I don't know if Ashley did anything else to add. I can defer to Secretary Sanders on things. Yeah.
Okay, so this is the change in expenditures by service category, which we've talked about, and as I said, pharmacy and hospital outpatient being the two biggest drivers. Now, this year, for the first time, we did a more detailed dive on pharmacy rebates. We have always collected information about pharmacy rebates, but they were in the net cost of private health insurance. They were treated as essentially a revenue item for the health plans. I know Caitlin has done a ton of work on this subject, so I know she'll be talking about it, so you can correct everything I'm misstating. Keep track of it as we go. So we decided to do a much deeper look at rebates and be able to attribute the rebates to the pharmacy spending and see what impact that would have. In this slide, and there's more in our slide deck in the full report, but this shows a couple of things. One is that you see on the left-hand side is the pharmacy spending, total healthcare expenditures, without the rebates attributed to them. And so you see last year's significant increase of 12.1%, whereas on the right-hand side, once you've attributed the pharmacy rebate to the pharmacy spending, you see that the increase last year, instead of being 12.1, would have been 7.3? 7.2. And by the same token, this year, 6.4%, which is the number we've been using in the slides up until now, that's kind of the gross increase in pharmacy spending, but if you attribute rebates to it, it becomes a 6.1% increase. So we did see a significant increase in the amount of rebates from 14 to 15, and it does have a significant impact on, and we don't make value judgments about sort of are we spending too much on pharmacy, because that's really, it's a function of kind of what we're getting for it. And by the same token, it's not for CHIA to say, is this the right level or what have you, but certainly there is a substantial amount of rebate spending going on related to these drugs. And do we have no, we don't, too bad. We actually have a slide in the full report that shows the percentage of rebates, the percentage of purchaser gets back from their spending, and it varies dramatically from commercial spenders getting commercial purchasers getting just over 10% back to, I think, Mass Health getting more than 50% back. And that's a function of both federal law and the nature of the program, the types of drugs and the utilization. But anyway, the report has a whole bunch of good detail this year on rebates, and I encourage folks to look at that. But Kate, are there things you'd like to point out?
I think the only other piece that I'd point out on this chart is sort of looking at the deceleration of pharmacy spending in 2016. So we see that in 2015, on a gross basis, pharmacy spending grew by 12.1%. This year was cut nearly in half at 6.4%. I think that's one of the more notable trends that we observed this year, and I think that contributed quite a bit to the overall slowdown we saw in expenditure growth across the Commonwealth.
Okay. The next thing we're going to take a quick look at is adoption of alternative payment methods, and there's very good news to report on this front as well. Last year there was flat, and there might have been some minor declines, but this year we see a fairly significant increase of 6.3%, a 6.3% increase to 42% of the commercial market now being covered by contracts that are alternative payment methods. So a very significant 1-year increase after the slight decline that you see last year. In the Mass Health market, it's been more stable, although you do see a slight decline in the MCO market and a slight increase in the PCC plan, but this is prior to Mass Health's ACO push, so I think what you'll see obviously is a dramatic change in these numbers going forward. So we've established the baseline, which is nice, and we'll get to see the impact it has, which will be exciting. We also took a look at enrollment and changes in enrollment, and we broke it out by employer size. And what you see here is that overall enrollment is very stable. It increased 0.8% from 2015, so no significant increase there. The vast majority of people continue to get their insurance to employers, and those numbers, as I said, are fairly stable, small numbers up and down. The only exception to that, at the very top, is the individual market, and you see that it increased by 34.5%. So we had a very large increase in the individual market on a percentage basis, but it's still a small slice of the overall market.
Jim Ray, I couldn't resist. In the past, I and I think several of the commissioners have been quite critical of the payers at point, particularly Blue Cross, when it took a little longer to get the alternative payment into the PPO. I think we should acknowledge on a positive front, it seems like it's working. I noticed that a significant, not as much as we hope to get, but a much greater growth in the PPO alternative payment. So where I could be critical, I just want to say, keep it up.
That's a great point. Yeah. Do we identify individual plans in the report?
We do.
Okay.
I read that with very much interest.
Yes, and a great job. And there was a significant increase in penetration of alternative payment methods in the PPO market from, I think, only 1% up to now around 15%. So great work. So we're starting to look at enrollment changes by employer size, and so that slide presents that information. There's quite a bit more breakout on that in the overall report. This is a closer look at the individual market, and as we said, it had grown substantially in from 2015 to 2016. What this slide shows is that it's overwhelmingly the cost sharing, the connector care enrollees. You see the dark blue band at the bottom is not changing significantly. The lighter blue band at the top is where the growth has been. Those are people receiving cost sharing reductions through state and federal programs. They previously uninsured.
So we know during this time period in 2014 and early 2015, several public programs were closing. So while we don't track people as they move through the healthcare system in this data source, it would be safe to say that many people may have been coming from Mass Health temporary coverage or from Commonwealth Care, other programs like that in the public space.
300,000 of it is temporary coverage.
I'm sorry, I didn't get to the.
I'm looking at the 2015 growth.
Right, saying that growth is not from the temporary. Right, no, exactly. Yeah, this is too that growth is too large to. So, any other questions on this slide? Okay. This shows enrollment changes by product type, and this actually gets back to what Stuart was just saying about the increase in. Oh no, I'm sorry. I was thinking this was this product type, not the APM adoption. But anyway, so what this slide shows is that the product mix in the Massachusetts market has stayed relatively stable in terms of HMOs, their share, but you did see in 2016, kind of for the first time, significant change in the amount of PPO penetration. As you saw, at least the GIC was shifting a large chunk of their members from PPO to POS plans, and so you see that shifted between the PPO and POS in 2016.
You know, Ray, I noticed in some of the material you put out, you combine the HMO and the POS. I will admit, trying to explain the POS market, it's really confusing, and I don't know where it fits.
Right, it's sort of a hybrid.
It is very much a hybrid, but it is now. At one point, it was a much smaller number, and you referred to the GIC plan as moving into that. I don't know whether you want to make another comment or two about why you put it in one category or another.
Sure. So this was actually the first year that we worked out POS as a point of service plan as a separate product type. I think in the past, we had heard from some payers that it was difficult for them to break out this at the level of detail we were asking for in our data request. They were able to do it this year, and it went over quite well. But as you said, POS is kind of a hybrid product, and my understanding is that by adding that PCP gatekeeper component, it's supposed to lead to better care management with lower costs to the system, which of course we can't speak to certainly on.
All right, and just a few last slides. So this one looks at fully insured premiums and self-insured premium equivalents. So this is looking at the cost, the cost of insurance side of things and how that's changed during the course of the year. And what you see is that a 3% increase in self-insured premium equivalent cost to $504 per member per month. Fully insured premiums increased by about 2.6%. Employer-sponsored only fully insured premiums increased 3.9%. Other things to call on this slide is this. Although there's more detail in the report on. This slide shows us about the penetration of high deductible health plans, and you can see the orange line and the orange circle. That's the total, and so you see that the total penetration is now up to 21.8%. So more than 1 out of 5 plans in the market is now a high deductible health plan, and this is using the IRS standards for categorizing plans as high deductible or not. And what you see is kind of higher adoption of them in the small, mid-sized, and large market. Jumbo, much less so. And you do see a significant change in the individual, the uptake of high deductible health plans by people in the individual market, and that's because the subsidies available, they can purchase plans that are not high deductible. Right? Remember this IRS definition. 1,300 for self-only coverage, 2,600 for family coverage in terms of the deductible amount. And then this is the last slide. This shows cost sharing, and we broke this out by employer size. I think it shows some interesting things. And of course, what you see is that well, the individual cost sharing is actually relatively low and declined by 8%, 2015 to 2016. That's because of the large number of people in the individual market moving into connector care plans. But otherwise, you see in the small group, the mid-sized group, the large group, that the dollar amounts are larger and that the percentage change, 8%, 8.7, 5.5. I think overall the increase in cost sharing for 2015 to 16 was 4.4%, so higher than inflation, higher than healthcare cost growth, higher than wage growth, really any of the comparables. Healthcare cost sharing continues to grow. And that's our last slide, I think. So happy to drill down on any of them or any of you.
Comments or questions by fellow commissioners?
Thank you, Ray. This is a more general question, so it goes back to your slides aren't numbered, but one that says per capita total healthcare expenditures, a line across it and then circles. I'm just struck at the way, some circles lying above this orange line and some below. And looking at, I'm trying to figure out, if you're looking for outliers, are the outliers the ones in the middle, or are the outliers the ones at the two ends? In your opinion, I mean, how do you see it as a trend at all? Because I'm just struck at how different it is. I would have thought it's a trend, the ones, and I know that this isn't a final number for 2016, but I don't imagine it's going to change all the way up to where the hurricane ended. So I'm just curious if you have a sense of what does it mean?
No. That's a big question, and I think we're supposed to be the data people. So I think what it shows is that I think what you don't see is a clear upward trend or a clear downward trend. I mean, what we're seeing is variability, but at around the numbers that we were hoping for, like around the benchmark. I think if you take the average across all the years shown up there, it's right around the benchmark. So for what that's worth. I mean, I think what it shows is that we have variability, but at a moderate rate of growth, at least compared to some of the rates that we've seen in the past, or some of the individual components of growth that we've seen in recent years. But this is a fairly new exercise for the state and measuring this stuff, and I think that we're getting to the point where we'll have enough longitudinal information to start talking about trends. It's a little hard in light of the the initial and final numbers, the way they shift, and the short number of years we have. It's hard to say anything too strong about trending. But the folks here would have more to say.
I would just add to that the average growth, if you take the 2016 initial across these years, is 3.55%, so below our benchmark. I think, but it is interesting. There is some volatility from year to year, and I can look at each one of these numbers and point to something unique that happened in that year that drove that. In 2013 to 2014, this was the year when we had the temporary coverage and enrollment had spiked in terms of some of the programs. And so that was a big driver, but that stabilized and went away. And then in the next year, we had pharmacy that grew at 12%. And that looks like an outlier now compared to where it had moderated. So there are these unique things that happen in each of these years. And I think part of what we try to do in our cost trends reports and the cost trend series is add the full context about what is going on with the state. So I think your question is right on, and one that we are going to be exploring with all of our stakeholders at the cost trends hearings, October 2nd and 3rd. Please register online. Thank you.
Well, that discussion sort of presaged what I was wondering about, which was how to account for the reduction in the increase in spending. And I was sort of wondering how much of it was because pharma rebates or price increases and things like that, whatever was going on. I'd known about the mass health, but that's why I was so surprised to see the mass health numbers being high here. So I don't know if that's going the other direction or something. But something that looked at how we got from 4.8 to 2.8. And what about like the core services that are provided by local providers in some of the markets versus the other things we don't have much control over?
Right, I know that, I mean, we're curious about that ourselves. In some ways, our job is really just to collect the data and make sure that that's solid, and then, you know, put it out into the ecosystem for smarter folks like you to actually answer those questions. But so you're asking me. No, but I think we do have. I mean, we've puzzled over it and we've looked at some sources and tried to get a sense of it, and we do have some theories as to what's going on.
Sure. So I think we saw some deceleration in hospital inpatient, and I think the pharmacy kind of deceleration was also a huge driver of what we see at the 2.8%. I mentioned earlier that pharmacy was still growing at kind of a high rate for Mass Health and Medicare. However, those were still quite a bit lower than from 2014 to 2016 or 2015 rather. I think in terms of what lies behind that pharmacy trend, our aggregate data can't really speak to that, but as a national market, we can look at other data sources and see sort of that there's a variety of factors, such as with like hepatitis C drugs, as folks were taking that, since it's curative, people take it for a year and then they don't need to take it anymore, so that's sort of like a one-time cost. We saw sort of some certain generics that weren't coming onto market, that hadn't come onto market are now coming onto market, so that's helping, I think, with the pharmacy trend. We're seeing sort of fewer price increases as there's sort of increased awareness of pharmacy pricing. So I think a number of factors contributed to that pharmacy slowdown, which in itself contributed to the overall slowdown. I think the last thing I would note is that the interesting thing is these trends are very similar to what we see nationally. So in the kind of national health expenditures model and other similar measures that are different from THCE but try to measure something similar, we saw sort of higher growth numbers in 14 and 15 and then quite a slowdown in 2016. So I'm not sure if that's comforting, but it's certainly our findings are consistent with what we see nationally.
Well, let me just change the nuance a little bit on the national. Put this into some context, which I've tried to do before. Two things. First of all, the state picked a number, which I think is a good number, so I'm not criticizing it, of comparing this against what we call long-term growth of the state. We should bear in mind that it's like the average tip, which we haven't met in the last 5 years. So we're not growing as fast as that average. So when you say that healthcare spending is under the benchmark, that's good, but one ought not to then go away and say, okay, we won this war, and we can forget about it, because it is still growing significantly faster than our growth rate and significantly faster than inflation. So, this is not time to sort of just, okay, let's forget about it. The second thing is to bear in mind that we are still part of the United States. Sort of, kind of. For the moment. And getting back to your comment, the way I look at it is how well we're doing at times relative. And you will see the discussion in our reports that we issue that David Axelrod and David Selson pointed out, that while the overall trends are there, we're doing better over the last 4 years than the national trends. And that if you look at rate of growth, Massachusetts, which is a very high-cost state, at one point was the highest, within the growth rate, we're one of the lowest over the last 4 years. And as a result, we are no longer, the Olympic event winner when it comes to spending per capita. So, yeah, the trend lines are similar, but we are doing better. And in many respects, when I think about our numbers, I think about that more than whether we're beating the benchmark or not. How we compare, because a lot of the trends that we face are that our providers and our payers face are very similar to the trends that are going on in the rest of the country, and the fact that we're doing a better job. I think our providers and our payers deserve some credit for that. And we will continue to look at that. I was just, David, a couple reminded me, CMS has not come out yet with their latest numbers, I think, is that what you were saying? So we can't compare these numbers yet to where CMS is projecting that they were at 60, but we will try to provide that information as soon as we can. So, any other questions? Ray? Again, thank you. This was a wonderful report. You guys do credit.
Thank you very much.
Okay, we're now going to switch gears here. David, I'm going to turn this back to you to explain our next session.
Great. First, just wanted to thank the CHIA team and Ray for their hard work on this report. It was an excellent report. And Ray will be back with us at the cost trends hearings, presenting some of these findings again, just to lay the foundation for those hearings, but also some additional findings. And we are working with that team to provide Mr. Chairman some comparisons on the national trends between Massachusetts and the United States, as well as really looking at some of the affordability challenges that remain for residents in Massachusetts and what some of these trends may mean. So we'll be teeing up the cost trends hearings for a much deeper dive into some of the questions that were raised just now. We're switching gears, and we are so pleased to have with us here today leadership from HPC Senior Life. HPC Senior Life is one of our awardees in the Healthcare Innovation Investment Program. And we are just so thrilled with the work that they are doing that we invited them to come here today to present to this board and to the public about the work that they're doing. They were recently awarded the grand prize by the Pioneer Institute, who recognized them as this was the Better Government competition where multiple different organizations can submit their models for doing government better. The focus this year was on aging, and so we were thrilled to be able to go to the Pioneer Institute's annual event where the governor spoke and where HPC Senior Life was recognized. So they're going to be presenting and talking about what the model is that they're working on, and as with all things with the Healthcare Innovation Investment Program, it's not just about this particular awardee and this particular model, but really thinking about how we can learn from and spread and scale the activities that are happening here. So I'm going to turn it over to them to introduce themselves and just kind of talk through their great award.
Thank you, David. So my name is Lou Wolf. I'm the President and Chief Executive Officer of HPC Senior Life.
Hi, Kim Brooks. I'm the Chief Operating Officer for Senior Living.
And so first off, I'd like to thank you all for having us here today. Thank you for having us be an awardee. This award has gone a great distance in allowing us to pursue and demonstrate the value of integrating housing services with senior care services. And importantly, it also led to us getting some more funding for this program because of the credibility of the Health Policy Commission endorsing this program, and also demonstrated to other providers who are part of the population health management continuum that are outside of the traditional healthcare system, that there is a recognition of the value of other providers bringing to this. I have the good fortune, I'm on the Mass Hospital Association board, and because of my role, I've been asked recently to chair a Continuum of Care Council for Mass Health and Hospital Association, and there's a lot of members who come into that who are non-traditional providers, and the recognition of this award to HPC Senior Life has empowered many of them to feel as though there's recognition and that they too can make a difference and be recognized. So I think there's a lot of leverage in that. So we have about 15 minutes to present, and so my goal here is to give you a little context for our work, and to do that in less than 5 minutes, and then have Kim go through the details of this program. So you have all these slides are available to you. So I'm just going to give some highlights of this. So this slide, I'm going to try very hard not to blind you folks. This slide has a little bit of information on Hebrew Senior Life, 113-year organization, broad organization, 2,600 employees servicing over 3,000 seniors every day. And importantly, we are in healthcare, we are in senior living and housing. We are also a research and teaching institution affiliated with Harvard Medical School. So when you look at this slide, you see that we are in a very, very wide array of services. But the big topic here is that our overall commitment as an organization is a commitment and a passion to really redefine the experience of aging for seniors. And so you see a lot of services here, but the important thing is that you take a program like we're going to be talking about today, offering the right care in the right place at the right time for seniors, particularly in affordable housing. So it also is the right population to be focusing on, a very high use population. For those of you who might have read Awardee's article, The Hotspotters, several years ago, it really focuses on this population being a highly vulnerable, high user of healthcare services. And this program really is the integration of senior living and healthcare and the research we're doing and the teaching that goes on with the residents, as well as the staff and other providers ultimately. So this is a look at our communities, and center communities of Brookline in the upper left, the Jack Satter House on the top, and Simon C. Fireman Randolph in the center are all affordable housing communities with around 1,000 people living in them. And that is the focus as far as our communities of this project. We recently went through a process of taking that promise to redefine the experience of aging and look to be more strategically focused. And so this slide just lays out a couple of key elements that are relevant for this program. So the first question we wanted to make sure we are focusing properly on, who is it that we want to focus on? There's a lot of people, turning 65 and 70 every day. There are a ton of organizations that are looking at that as a market opportunity and focusing a lot of services. But a lot of the folks that we want to focus on, which is primarily the more vulnerable and underserved amongst our population, low income, medically complex, people with behavioral health issues, are not necessarily the folks that the market is focusing their attention on. We also very much wanted to focus our attention on the bottom here on healthcare and senior care organizations and policymakers to be able to pursue some programs where we can really demonstrate value to see if we could change policy and how other providers function. So on the right, you'll see we wanted to try to be very specific about what outcomes we wanted to generate for the seniors in our communities, in their homes, and others we could affect. So you can see our version of the triple aim there with the health of our seniors, their personal satisfaction with their life, and importantly, cost effectiveness. So one example of this is this Vitalize 360 program that we have in all of our affordable housing. And you can see in the upper left-hand corner, there is a bit of a description where we have all of our residents in coaching programs, and they have assessments done on them, their physical state, their mental state, their psychological state, and we create goals for folks. So the average age of some of our communities in independent living is 90. And many of these residents comment on the fact that no one has asked them about their goals for decades. They rally around that and they come up with some great goals like going to a granddaughter's wedding or maybe dancing at that wedding. And it leads to a lot of very committed programs for them to reach those goals and to feel passionate about them. This is now a program you'll see in the lower right that not only do we have in all of our communities, but we now have in 28 other communities around the country who have embraced this. So, it's an example of the taking people in housing and infusing them with a lot of other services and encouragement and integration with their healthcare to great benefit. So the last slide that I'm showing is just, it's an array of different future approaches that we are taking in order to fulfill this greater strategic focus And 3 of these are very relevant to what Kim's going to be talking about with our R3 program. So in the upper right-hand corner, a very, very strong desire to reach more seniors out in the community rather than in our facilities, and reaching them earlier in the process, in their aging process, in their healthcare process. It's what people want, it's what we want, it's where it will become more cost effective. The lower right, we're looking to, as are all other entities that aren't ACOs or acute care hospitals, engaging more in healthcare reform and population health management. And in the upper left-hand corner, there really is a commitment to do more research, do more teaching, and to deploy the intellectual capital that gets generated from our organization to others to really leverage those benefits. And you'll see this replication of this model of affordable housing with supportive services. We feel as though it has great value. Everybody who's in the affordable housing business intuitively knows the value this brings for lives and cost management, and to have the opportunity to demonstrate that is a great opportunity for us.
Thank you. So thank you. We are really excited to share an overview of our initiative today. And R3 is all about embedding wellness teams in affordable senior housing and proving out the value of what we believe to be true, that not only does it have a positive impact on seniors' lives, but also on healthcare spending. So we believe with the right linkages between healthcare and housing, we can create a sustainable model that can be replicated and not rely on grant funding moving forward. We have engaged a really great group of partners in this work, everything from local health plans, SCOs, PACE providers, to the area agencies on aging, the aging service access points, and our local emergency responders. And from a timing standpoint, we are finished with our 6-month preparation period, and we started our 18-month implementation on July 1st. So most importantly, thank you so much for your investment in us. The $420,000, not only allowed us to get this going and actually start doing this demonstration model, but it also, we were able to leverage that, as we mentioned, and go out and double that funding. And so we now have this pool of about $1 billion that we're working with. And you'll see all the funders up there, including our colleagues at Mass Housing and Department of Housing and Community Development, which has been a great partnership. So that funding has allowed us to expand to 2 regions. We have a Brookline region, and then we have a Randolph and Milton region. And 2 teams deployed, 1 at each of those. And we are serving seniors that live in 7 different senior housing communities. That is representative of a number of different ownership groups. So some of those sites are Hebrew Senior Life Housing that you heard me talk about. And then additionally, we're working with WIN, who is a national provider of affordable housing. And also Milton Residences for the Elderly, a local nonprofit who has 2 sites. So we have we've recruited and enrolled 400 seniors into our model, and that was our goal. So we were excited to reach our goal. We believe that we will have impact not only in the 400 that are enrolled, but also the 1,100 that live in those buildings through the programs that we're implementing. And then I also included here, we're utilizing the additional resources to also engage with UMass Boston and do a comprehensive evaluation of the model. So we now have this, it's a true research study. We are doing pre and post analysis, and we have a control group, and we will, UMass Boston has been engaged with us since the beginning of the prep period and has been working with us on the design of that. There are also a couple of other studies happening at the same time. We've been working for the last couple of years with a local group of health plans and housing providers through Leading Age. And so that work is very aligned with what we're doing in R3. And then, our aims and key performance indicators are very aligned with what you heard Lou talk about in our strategic goal of measurably improving seniors' quality of life. Our primary aim is a reduction in transfers to hospitals, emergency rooms, and long-term care by 20%. And then our secondary aims are all around increased utilization of wellness programs, linkages to mental health, and then a reduction in rehospitalizations. You'll see down on the bottom our key performance indicators are all around the aims, and then additionally on some of the key risk areas that we know contribute to those challenges, like falls, medication adherence, and routine wellness checks. So we are getting great data from our emergency responders, and then we have implemented a lot of tracking tools internally to measure our KPIs. We believe we're going to have some challenges getting data from the health plans and the hospitals, so we're doing everything we can to track as much as possible internally. We also realize the reality of the short time frame that we have, and it's 18 months is going by fast, and we are very hopeful that we can have some impact in such a short time. So on the question of what are we actually doing, what are these teams working on, and where are we? We have, as I said, engaged the 400 seniors that are enrolled, and we've completed baseline assessments on all of those. We're using our Vitalize 360 system that you heard Lou talk about, which is a research-based assessment tool and then coaching model. And we are using the information that we've gathered from all the assessments to bring programming that actually meets the true needs of the population living in each of the buildings. So, for example, we have one of the buildings of our partner sites who has a number of seniors struggling with diabetes. We're able to bring chronic disease management specifically around that topic to that building, meeting the actual needs of that population there. And then we're also tapping into a lot of the existing wellness programs that the aging service access points have, that the health plans have, and just matching those up to the buildings that make sense based on what they have to offer. We're also, we've done resident surveys in those buildings, so we're able to bring programs that really meet their individual interests and help them meet their goals, whether it's about brain health or mindfulness or end-of-life planning and getting their healthcare proxy in order and all their affairs in order. And we have utilized that coaching model that we talked about to get at what matters most to them and really help support them to live their best lives. The partnership with the housing staff and the health plans is really about helping people, supporting them through transitions back and forth, if they have a hospitalization, identifying changes and needs early on, and trying to really communicate so that the health plans can take advantage of all the eyes on that housing has on these people, in the place where they spend about 90% of their time. Our teams also are doing monthly check-in calls, where not only are they gathering information for our key performance indicators, but they're also identifying needs early on and helping to intervene wherever may be necessary. For example, we've had a number of occasions where a senior in that monthly call talked about their planned trip to the emergency room. They were about to go to the emergency room because basically they needed a doctor visit, and whether they can't manage the logistics or the transportation or navigating the primary care system, that's their solution. So our team is able to intervene and actually change that course a bit. And then our emergency responders have been unbelievable partners. We get data, more data than we know what to do with. We know every day of the week, time of the day, reason that people are going out, how many times that's happening. And we're working closely with our process improvement team on the analytics, and then with the emergency responders on everything from inserting our housing staff into that model so that we can hopefully intervene wherever possible. And then also doing a lot of education with staff and residents about what happens when you call 911. At the same time that all this is going on, we are actively recruiting and conducting baseline assessments for the control group. So we have been working on gathering a few control group sites so that for the evaluation study we have the intervention in the control group. And then our long-term goal is really about creating a model that can be replicated, one that is sustainable, that shifts a portion of the spending that happens on the back end to some of these preventative wellness models on the front end, and that take advantage of the efficiencies that we can gain by having hundreds of seniors living under one roof with a team that knows them really well. There are about 2 million seniors living in affordable housing in this country, so we feel like even if we make a small reduction in the transfers that we're talking about, we can have a significant impact on the cost. We know we have a lot of work to do. There is to align all the multiple payers. Each building has anywhere from 8 to 10 different health plans that are engage with a very small number of residents in that building. So working with all of them and trying to align all the models, a little challenging. And then also getting their attention when they often have a very small contingent of people in one place. And then there is also the challenge with housing providers from a replicability standpoint, getting housing providers everywhere to realize, this is going to be beyond a landlord-tenant relationship. This is much more than that, supportive housing as the words of this. But given all that, we are certainly optimistic, and we look forward to coming back in 18 months and hopefully sharing good results with you. And thank you very much for the opportunity today to talk about R3 and about the benefits of supportive housing.
Great. That was terrific and very exciting, kind of given the process that we went through to evaluate all the proposals. You just answered part of my question, but if you could flip back to aims and key performance indicators, you said one of the potential problems you face is getting information from payers and from providers. Is that primarily because of the small number feature that you just referenced? Is it patient identification? And I think most importantly, is there any way that the commission, given our connection to the payers and the providers, might be able to help with this? Because absent those data, it's going to be hard even to proxy up the cost savings.
It is, and yes, we would love your help. We haven't given up yet. We've had many partner meetings. We've got our different groups engaged at different levels. I do think a lot of it is about the numbers and the limited numbers. We found once we did all the baseline assessments, we learned that many more people have fee-for-service than have, than are in a SCO or in a Medicare Advantage plan. So right out of the gate, we already have smaller numbers that we can engage those payers, those health plans in. And we haven't gotten there with the hospitals yet, so I don't know how that's going to go. But yes, I do think it's about numbers.
Yeah, no, numbers is a big part of it because when you do have a building and you have 10 people on this and 15 people on this, that particular SCO, that particular PACE program doesn't have enough of a critical mass to really focus the attention. So you have the opportunity where you might have 100, 150, 200 people in one place. They're the most underserved, oftentimes they're heavy spenders, and they are and a staff in housing, it knows them inside and out. One of the Mass Health ECO meetings I was at, there was this kind of what became a kind of a famous comment about a person who's in a housing site knows that this person will never comply with anything unless they get a cat sitter. So it's like the cat sitter example. And there's no way that their SCO provider, their nurse knows that. So to the extent that there could be a way where there was less choice about what health plan you choose if you are in an affordable housing setting. That it's not about choice of health plan; it's about choice whether you want to live there or not. There's some heresy to that, but that's. But also, I think there's a HIPAA issue where many people are so afraid of HIPAA that a health provider can look at a housing provider and feel like there is not a need to know there. So that barrier in making the housing employees and staff part of the healthcare team is a nuance that we can get over as well. So those are a couple of barriers.
Thank you.
Thank you very much, both for the presentation and more importantly for the work that you're doing. And I'm so pleased that you're focusing on housing. Part of me feels that if we took a big chunk of the money that we spend on healthcare and just put it into providing secure, affordable housing for everybody, we would actually lower costs considerably. So you're starting down that path. I'm a pediatrician, so I'm at the other end of the age spectrum. And so I'm curious about intergenerational work, if you're doing any of that. I think even when you mentioned cat sitters, I think for seniors, connections are very, very important. And whether they're to their own family or to somebody who cares about them or that they can. And the other thing is seniors have an awful lot to offer, I think, in their wisdom, their experience, life experience. And are, so I'm curious if you're making any efforts to connect the seniors to younger generations, for example, and to use them as caregivers, as advice givers, and that sort of thing.
So we do. The multi-generational programming is a huge component of our work across all of our communities, including the affordable housing sites. It looks a little bit different at every site, but connections with schools, with whether it's students coming through or actual connections with schools where everywhere from young children up to young adults are coming in and engaging with residents. We have partnerships with nursing schools where nurses come in and they'll do brown bag medication, and they'll they get to learn about gerontology and working with seniors, and our seniors get to be and work closely with them when they're there. So that is absolutely a large component. And then on the engagement, a lot of the programs that you heard me talk about, as we've been adding them for R3, we're often tapping into the Aging Service Access Point of the health plan. But a lot of the programs that happen in senior housing are being run by residents. So a resident who was a lawyer, who was an accountant, or, they're taking on programs and actually running them and giving back to community that way, and certainly feeling like they're having an impact.
Like I said something quickly, when we built the Newbridge campus in Dedham in 2009, there's a school on the campus, the Rashi School, and that was our first foray into really multi-generational programming, and it was such a huge success, both ways, the kids, the parents, the seniors as far as engagement and their role. And then we got funding subsequently and have, as Kim said, a cross-organization, multi-generational program that has 75 separate initiatives. Last time we looked, every single campus has very proactive, and it is just such a win-win all around for everybody. Absolutely.
Well, this is wonderful. Thank you, Lou, and thank you for coming. Last year we had a special session of our cost containment cost review meeting, which Dave is going to talk about in a minute. And one of the areas that we focused on is the health determinants of health, the broader base looking. And this is a wonderful example of how moving out of the traditional areas of clinical care into places like housing, where you can make a difference on the health of the community. This is an excellent. So thank you so much.
As somebody who was in the acute care hospital for 15 years, I never appreciated what you just said as much as I do now. It is so true.
Wonderful. Thank you again. Wonderful. David, turn it back to you.
All right, thank you, Mr. Chairman. And I just, the last agenda item is my executive director's report. So we'll walk through a few updates, but we did want to say thank you again to Keep Your Senior Life. And we will, from time to time, both in the board meetings and at the committee meetings, bring some of these awardees through our investment programs to come and present. And I really think it's an opportunity to learn from some of the incredible work that they're doing. So we'll look forward to more of these types of presentations in the future. So for my executive director's report, moved around our typical notice of our presentation on material change notices. Since 2013, the Health Policy Commission has received notice of 83 provider transactions, with clinical affiliations continuing to be the most frequent, followed by physician affiliations. We have a number of notices that are still under review with the Health Policy Commission, as highlighted on this slide. And we did receive one new notice since our last board meeting, specifically Baymark Health Services, which is a national for-profit provider of opioid treatment services in 20 states, intends to acquire the for-profit Community Healthcare, which operates substance use disorder treatment programs in 10 locations in Massachusetts under a new name, which will be Healthcare Resources Center. The parties have stated to us in their initial notice that they do not intend to change the operations or the programs or the services that are being provided by the local organization, but we will conduct a review of this and report back. We do have one cost and market impact review that is still in progress with Health Policy Commission. which is the proposed acquisition of Mass Eye and Ear by Partners Healthcare. Are there any questions on the notices that are under review or the current CMIR under review?
What's the timeline, David, to bring these, the three that have been on for the last couple of agendas, what's the timeline to bring those to the review?
So each of these notices that are currently under review on the top part of this slide, they have not yet completed full documentation required to us as part of the material change notice submission. And so we are still in a back and forth in getting those materials. So the 30-day timeline by which we will have to conduct a review and make a determination about whether to move forward with a cost and market impact review has not yet begun for each of these transactions. So we will let you know when that happens and when the 30-day clock begins, but it has not yet begun. So wanted to provide an update on our upcoming cost trends hearings, which will be the next time we meet together as a board on October 2nd and 3rd. I'm extremely excited. This is our 5th annual cost trends hearings. We've come a long way since the first year that we held it at UMass Boston out on that point in that large room. We are having it again at Suffolk Law School, so very convenient for everyone here. And we will be, of course, live streaming the hearings as we have in the past. Encourage everyone to please register and reserve your seats. We do meet full registration usually every year, and so please do that. And, there's plenty of places on our website to go and find where to do that. So want to talk a little bit about the agenda that we've sketched out for the cost trends hearings, and as commissioners, you know, we give you a great deal of information prior to the cost trends hearings in order to prepare you for those hearings, and expect that you'll get a lot of information from us in the weeks to come. But I'm pleased to just kind of walk through a little bit of the agenda that we have sketched out for you. I'm very pleased to notify you that we have confirmed Charlie Baker, Governor Baker will be providing remarks, as well as Senate President Rosenberg, Speaker of the House DeLeo, and Attorney General Healy are all confirmed to give remarks on the opening of both cost trends days. And here we see the agenda for the first day, and I would note, given some feedback from the board, we have attempted to streamline these days a little bit. So you'll see that these are not 2 full days as they have been in the past, but we'll conclude our business in the early afternoon on both days. So we have a couple of different themes that we are expecting to discuss and have built panels around. The first witness panel will be focused on strategies around reducing unnecessary hospital use. So this can be both emergency department visits, readmissions, admissions, ED boarding, many of the different metrics that this commission has identified as cost drivers in areas where the state candidly lags the country in terms of our performance. In the afternoon, we're going to have a witness panel that will be doing a retrospective look at some of the market transactions that have occurred in Massachusetts over the last couple of years. We'll be providing for the first time some data in terms of how we've seen some patient flow changes post-transaction. We'll be able to present that information publicly and then engage in a discussion with those actual market participants about what they have seen since that transaction, both positive and potentially challenging in terms of the impacts of those market consolidations and relationships. On the second day, we have, beginning the day, a panel that we're going to focus a little bit more on the financial incentives and our progress in payment reform and how payment structures are impacting our ability to both meet the benchmark and improve healthcare spending, as well as engaging with employers and others around how are they innovating in this space in order to be able to drive patients to high-value care. And then finally, we kind of have a catch-all panel to close out our hearings, which is, we'll cover, I think, a broad range of different topics around how we achieve the healthcare cost growth benchmark, and more importantly, our triple aim goals moving forward in the Commonwealth. So I can expect that these topics will both reflect some of the themes that have occurred over the 2 days, but could also touch into some other areas that have been of interest to the Commission in terms of workforce issues, administrative simplification issues, physician satisfaction. And so expect a broad range of topics on that final panel as we think about how we improve our healthcare system moving forward. So expect a closing conversation with the commissioners and an earlier release of the cost trends hearing this year. So one other topic that I just want to note for you and for the public is that as part of this process, we collect pre-filed testimony from about 60 different organizations in Massachusetts, health plans and providers, where we ask them to provide written testimony about what are the strategies that they are pursuing across a number of different areas, what policy recommendations they have for the Commission. And so staff will be compiling and synthesizing and summarizing all of that written testimony for you and for the public. And for the public, we do post every one of those written testimonies on our website, so you can go to our website and see a whole range of just almost hundreds of pages of information, kind of crowdsourced from our providers and health plans around what they see as some of the biggest challenges in our healthcare system. So it is an incredible resource that we want to leverage as well. So happy to take any questions on the cost trends hearings. Otherwise, you'll be prepared to hear a lot from us in the next couple of weeks.
Any comments, questions?
So a few final updates on some of our programs that we run. I'm going to start first with our care delivery certification programs, starting with our patient-centered medical home certification program. Just an update here on the number of practices that are participating in this program. Extremely pleased to report to you that we have broken the 100 mark in terms of practices that are participating in our program, either fully certified or who have made a commitment to be certified in a certain time period. Just really pleased. This program continues to grow, and every month we continue to add practices that are interested in participating with the HPC and how to provide excellent behavioral health care in a primary care setting. So really excited about this, and would note, since the last board meeting, we did have basically a kind of a learning session with many of these practices around how to provide medication-assisted treatment in a primary care setting, and had great participation in that learning session, and highlighted some of the practices that have really been able to do this well in terms of providing MAT. And so we're continuing to learn from this cohort and provide opportunities where they can learn from each other. And this is a list of all the practices that have been fully certified, and you can see does include obviously some health centers, but also a range of other pediatric and adult primary care practices. The second certification program that I just want to give you an update on is our ACO certification program. And here we have a very close linkage with the Mass Health program. ACOs that are seeking to participate in the Mass Health program are required by Mass Health to obtain HPC certification of the ACO by January 1st. And we have worked really closely with Mass Health to make sure that this is truly a linked program with the efforts that they're doing. But what this means is that we are expecting at least 17 ACOs, which is the amount of ACOs that were accepted into the Mass Health ACO program, to be seeking certification from us in the coming months. And so in addition to the Mass Health program, we do have created linkages with other state agencies. The Health Connector is now asking their health plans how they are engaging with providers, including providers that have been certified by the Health Policy Commission, and recently revised a determination of need regulations by the Department of Public Health, reference ACO certification for certain providers who want to build freestanding ambulatory surgery centers as being a prerequisite. So really pleased that we've been able to grow this ACO certification program and have these linkages both not only with Mass Health, but with DON and the Department of Public Health and the Health Connector. We're all using this common platform from this program that we've built. So I could not be more pleased in how this has gone. As you know, this was a voluntary certification program, and so we've really worked hard to build these linkages. We do expect that this will be a very busy couple of months for us as we get 17 different organizations submitting significant information to us, and we'll be going through certification. So this is the full timeline. As you can see, this dates back all the way to 2014 when we started this planning for this program. And Dr. Allen, you have been a leader on this program for us through the CDPST committee, and pleased that we'll have be certifying ACOs in full speed ahead this fall. So it's been a long journey to get us to this point. Skipping ahead to our strategic investment program, so skipping ahead to slide 63, just really quickly on CHART. We are nearing the end of our CHART Phase 2 program. We have 88% of our program months are complete as of August 2017, and you can see the kind of blue lines. There is some staggering of when the different programs will be complete as far as the Phase 2 program goes. This slide I won't talk through, but again summarizes our extremely heavy engagement with our CHART hospitals, and I know a number of the staff who work on the CHART program are here today. They've been engaged in regional technical assistance meetings all week with our providers through this program, and just continue to use this program as a place for the different hospitals to meet and learn from each other about what they're doing. So even in these waning months, the hospitals are extremely engaged and excitingly sharing results with each other as the data has come in. Of the money that has been expended, we have dispersed about 36.4 million of the approximately 60 million that has been committed to this program. And so we do have around 22 million more that we expect to disperse before the end of the program. And as you may remember, we actually set aside a portion of these awards based on an achievement payment. And so a certain amount of these awards, the money is actually set aside for the CHART hospitals if they are able to meet some standards that we have put in place. So we did have actually some risk involved in terms of the way that we designed this program. And so you can see that that amount that is at risk is upwards of $7.2 million. So where are we today? Right now, we are working hard and offering to hospitals an opportunity to get a no-cost extension from the Health Policy Commission. So while 88% of the program months have been complete, as I mentioned before, we do expect that many of the programs will continue to provide services through a no-cost extension. So if they basically underspent on the award that we provided and authorized for them, we are providing an opportunity that they can continue to expend against their award and extend their program a few more months. So we're working through that. And we are also working on finalizing what their achievement payment will be. Were they able to meet their goals, and what can they expect in terms of being able to get access to that kind of that pool of money that was, I said, at risk for the hospitals. So we do expect with the no-cost extensions, with the achievement payments, and with the continued reporting that we are still going to be heavily engaged with this cohort for the next 8 months at the least. And so we'll report back to you as we continue to close out this program and as we get results. Would note that the Boston University School of Public Health is doing an evaluation, and we'll have some results, some initial results from that evaluation this fall. Finally, we'll just note here that we continue to promote the good work of these hospitals, and we're pleased to see that a journal accepted an article that we had written based on Hallmark's model at reducing ED utilization. And so, again, taking the learnings from this program and disseminating them widely. On the Healthcare Innovation Investment Program, which was the program that funds the Hebrew Senior Life, which we just talked about, all of these initiatives have now launched, and there's a couple of different pathways here. We had our targeted cost challenge investments, which is what Hebrew Senior Life received an award under. We have telemedicine awards, and then of course we have the neonatal abstinence syndrome programs focused on mothers and infants, substance exposed newborns. All of these programs are up and running, and we are starting to collect data through these programs. Here, however, as you can see, we are at the beginning stages of the implementation for these different grant programs. And so still at an early phase, and we'll be able to report back soon on more of what we're learning through this program. So I ran through that pretty quickly. I'm happy to take any questions that you may have just in terms of some updates of the certification programs, the investment programs, or any other activities of the HPC.
David, just on the ACO certification, I know we spent a lot of time on the regulations. I'm curious, we don't actually see the applications, but I'm curious as to the sort of level of response that you're getting, particularly around some of the more narrative questions around population health, patient engagement, behavioral health. Is it possible that you could share with us maybe an application that you're receiving, or have staff describe the level of those responses? And then also, as this is a new program and about as Mass Health implements, have we anticipated some feedback loops so that we're getting information back from Mass Health, from patients, from advocacy groups like Healthcare for All, that are looking at various components of the ACO regulation, whether the patient advisory committee, the governance requirements, so that we can then alter those regulations as need be.
So great question. So to date, we did run a beta process for the ACO certification. So we invited a number of the organizations who were in the Mass Health, ran a pilot program for their ACOs. We invited them to go through kind of a first user test of our ACO platform, application platform, and submitted full responses. So it was a great learning opportunity to kind of see what is the type of information we're going to be back from applicants through this process. And we are happy to kind of share those results with commissioners if you're interested. You know, that was 2 organizations. We did run through the entire process with them. We did end up certifying them. They met all of our standards. And we'll have many more that will be going through this process again this fall. Just as a reminder, the materials that they submit to us through the ACO certification program can be considered confidential. And in the way that we design this program, they have some optionality about whether they would like to keep some information confidential or whether they're comfortable allowing that to be public. We did find with the 2 first ACO applicants that they tended to opt for confidentiality. But what we expect to be able to do, once we receive all of the applications in, and basically the work of the next calendar year is going to be, how do we take that all in, synthesize and summarize across organizations, where are ACOs on all of the different things that you talked about? And maybe we won't be able to identify specific ACOs as kind of falling below, but we'll be able to do things like saying, you know, 15 out of the 17 ACOs had a program in place for end-of-life palliative care, or only 2 out of the 17 ACOs are able to do this. And so that, we believe, will actually provide a really good foundation and understanding where are these provider organizations in terms of their journey and being able to meet the capabilities. And from that, that provides a platform to say, how do we revise this program for the next time around? And how do we continue to evolve and change those certification standards so that we're constantly pushing and working with the ACOs to improve on what we want them to do. And as you'll remember, some of the standards we did are just information. We did not make them assessment criteria. They are required to respond to us about what they're doing, and end of life is an example of this. We asked them, what are you doing specifically on kind of end of life issues and engagement with patients? And they could say, we're not doing anything. And that is not assessed in the positive or the negative in this initial certification. Now, the commission may, at a certain point, return to those certification standards and say, actually, no, we want to move that up into the category of saying, we're going to require that you actually meet and do something here in order to be certified. And So we have some assessment criteria today and some information gathering criteria today. And the goal is to evolve that, learn, and be able to move things and move the bar up in terms of what we're expecting from ACOs. And as part of that process, we are, I think, in contact with Mass Health probably on a daily basis.
So similarly on chart, but at some point will we see a report on achievement against goals for chart?
Oh, absolutely. Yes.
When do you think we might start to see some results?
So we have kind of the full Boston University School of Public Health evaluation, which will take some time. We're going to get the final reports in. We'll have to do some kind of number cleaning. That will probably, I think, the final report from BU will not be to us until January of 2019. However, we do expect, we still have interim reporting, and we'll be able to share some of that information at a much quicker pace with you in order to share some really good results from this program. So while we want to, certain things will need to wait for the full evaluation to have everything kind of ticked and tied together. We have been getting monthly reports from these hospitals and can show that to you guys in terms of where we've seen some of these trends.
So just to follow on to that, obviously BU can't finish its evaluation until the no-cost extensions are complete, correct? Or are they kind of how will that work?
So with the no-cost extensions, my staff can wave me down if I'm saying something wrong here. We have stuck to the same 24-month period of performance. So the 24 months is what we will be evaluating and judging the organizations on. So to the extent that they are continuing their program, that will not be part of kind of the evaluation. So we wanted to, because that was the standard we set at the beginning, was this is the 24 months beginning, your beginning, your end. And so it will not impact the BU School of Public Health evaluation, but will provide them an opportunity to continue the work.
Right, and at what point will we consider their self-report or their own evaluation of their progress? At the end of the 24 months or at the end of the no-cost? Will the no-cost extensions go beyond the 24 months?
Yes.
Yes.
So, and our evaluation will be tied to the 24 months.
Thank you.
I'm thinking on the positive side. So is it possible that chart already or very soon could have lessons that we could feed into the cost containment work that we propose to do this year, because they overlap, so it would be great to, your enthusiasm comes across. There must be some things there that you can't wait to show us.
There are, and that is absolutely our plan. And I think we have spent a lot of time thinking about kind of taking the learning, having a learning and dissemination strategy for the organization. I think we have been always a little hesitant while the programs are kind of going through. We have some confidence now. We're near the end. We know these trends. We can see them and have confidence that what has worked. And that will provide, I think, an incredible opportunity to, not just for our chart hospital, but for all institutions to be able to learn from and say, here is a great model for kind of identifying patients, providing the right types of services, reaching them in their community. And that is really our goal with, as we kind of end chart, is not letting it just end, and really being able to harness what we've learned from it.
Great. Well, we've reached the witching hour. This was really an incredibly informative and important meeting, so thank you, David and staff. And are there any other questions anybody wants to bring up or comments? If not, I just want to remind everyone we have our next board meeting on November 1st. But more importantly, we have the 2-day sessions, the 2nd and 3rd of October, as David mentioned, at Suffolk Law School. So I assume everyone will be there, and we look forward to it. So with that, the meeting is adjourned. Thank you so much.
Information about that.